All right, guys, this is Mrs. S. Today we're going to cover in this particular video an introduction to intracranial pressure and then look at ischemic strokes, headaches, and seizures. So let's go ahead and get started. Just a reminder, if you have yet to look at the neuroassessment videos, do so. Want to make sure that you understand how to assess for an altered level of consciousness, remembering there are two components, arousal and cognition. Arousal just means, are they awake? Is your patient awake? Are they alert? This depends on an intact reticular activating system. So when someone is awake, then they have an intact reticular activating system, and then we want to check cognition. This is controlled by connecting cerebral hemispheres, and this includes memory, perception, problem solving, and emotion. As we have an impairment in our level of consciousness, it may be needed to elicit a higher amount of stimuli. So remember, there's verbal stimuli, which is just they'll wake up, for instance, to their name, to tactile stimuli, which would mean they would wake up, but you would maybe have to shake them gently, or deep stimuli, meaning that maybe someone would use nail bed pressure or a sternal rub. We want to check, and make sure our patient's not agitated or confused. If they're confused, then we need to be specific as to what they're confused. Typically, someone loses orientation to first time, then place, then person. So when you say someone is awake and oriented, then you need to be specific that they are oriented to time, place, and person. Just briefly go over the various levels of consciousness that you could actually document. Your patient could be alert, which means that they respond readily. They may be confused, but they are alert. They could be lethargic, just means that they're drowsy, but they can be aroused. They could experience obtundant, which means they are difficult to arouse. They can't make a simple, complete sentence, or it requires repeated stimulation to actually keep them awake. They could be in a stupor or be stuporous, meaning that no verbal response. They may moan. They may respond to painful stimuli by moving their extremities, or maybe they're comatose, and comatose means that there is no evidence of awareness. So, what in the world do Abby, Ruger, and Beretta have to do with intracranial pressure? Well, just like a human, they have a skull, they have a brain. The purpose of the skull is to protect that brain, and they have intracranial pressure, just like human beings. Also, there are three components to intracranial pressure, and these three components are brain tissue, blood, and cerebral spinal fluid. And so three components, three dogs: brain, tissue, blood, and cerebral spinal fluid. So let's explore how these three components make up intracranial pressure and hopefully keep at a relatively constant balance. There is a doctrine called the Moreau-Kelly Doctrine that actually states that these three components, the brain, the blood, and the CSF fluid, have to remain in a relatively constant volume in the closed skull in order for the pressure to remain constant or have constant intracranial pressure. It tells us that if one of the volume of these three components increases, if these three things do stay in constant balance, intracranial pressure, which normal reading is around 10 to 20, then all will be well. But if they get out of whack and the other components cannot decrease in capacity, then you're going to have a rise in intracranial pressure. It's called increased intracranial pressure, and above 20 is considered elevated, but if it gets greater than 50, then this leads to very unfortunate incidents such as herniation of part of the brain matter. When the brain is not able to compensate and keep the intracranial pressure constant and it rises, then what happens? The brain and its limitations are met and there's decompensation, and this decompensation results in vessel compression and brain tissue ischemia. Autoregulation of cerebral blood flow is a good thing. You guys know that we need a constant blood flow to the brain. It's critical. We have to have a constant supply of oxygen and glucose. And so it's a good thing that there is what we call autoregulation of cerebral blood flow. And what that means is that we just have a consistent cerebral blood flow, and it provides the metabolic needs of the brain tissue. And so what it does is it actually follows the systemic arterial pressure, okay? And we actually look at someone's mean arterial pressure, and we've talked about mean arterial pressures before in class. And so when we're looking at cerebral blood flow and autoregulation, we have to realize that it's limited, and that it is essentially limited to a mean arterial pressure of 70 to 150. So the lower limit is 70 and the higher limit is 150. When this pressure is exceeded, then the vessels constrict and cerebral blood flow regulation is lost. Often neurologists are interested in calculating what is called the CPP, or the cerebral perfusion pressure. And the CPP is the pressure that's needed in order to assure good blood flow to the brain. And as you can see, there's a formula. Don't worry, this is not test material, but it's the mean arterial pressure, just like we talked about, minus the intracranial pressure, and that gives us the cerebral perfusion pressure. A normal CPP is considered 100 or 60 to 100 millimeters of mercury. Less than 50 is actually associated with ischemia and can be associated with neuronal death. And less than 30 is considered to be incompatible with life. When we're looking to take care of someone who has increased intracranial pressure or having issues with their intracranial pressure, there are many different chronic neurological diseases that this could be caused by, and a lot of acute issues additionally. But in general, when you're looking at someone who comes in and has a neurological issue, there's certain things, certain diagnostics. Once again, you guys want to make sure that you've listened to the neuro assessment videos. But a lot of times we look to see what's going on in the brain, look at a CT and MRI. Possibly a cerebral angiogram to look at blood flow. An LP is a lumbar puncture. Look at the cerebral spinal fluid and look at the pressure within this cavity. A Doppler, once again, to look at blood vessels and look at blood flow. An EEG to look for abnormal brainwave activity. And then there's a whole host of labs that we could draw blood flow for and look at too. Medications in general, when you're taking care of someone who has a neurological issue, normally give them an isotonic, maybe a slightly hypertonic solution. We always want to check their blood glucose level. Do they need a little bit of D50 or do they need some carbs? We want to check to make sure that they have not experienced a neurological change because of an opioid, and that it could be reversed by the Noxalon, or what we sometimes call Narcan. Is there a thiamine deficiency? Is there an electrolyte disturbance? Specifically, is there a sodium disturbance? Sometimes we'll give diuretics. Specifically, what you'll learn in neuro is that we give osmotic diuretics. They work a little bit differently than what you guys are used to. And then sometimes antibiotics. Is there a neurological change based upon a current infection that could be treated with antibiotics? Some good nursing diagnosis for someone who's suffering from a neurological issue: ineffective airway clearance, certainly a declining level of consciousness. A lot of times can cause them to have ineffective airway clearance or place them at risk for aspiration. We could also certainly have ineffective tissue perfusion cerebral. This is a high priority, for instance, when we talk about strokes and seizures. Or maybe they have what we call a decreased intracranial adaptive capacity, meaning that they're having some kind of neurological issue that is leading to a rise in their intracranial pressure. Okay, the first topic that we're going to cover is stroke. If you are in my class, we're on page 1388. So again, if you're in class, we're on page 1388. And we all know that a stroke is also called a CVA, a cerebral vascular accident. Sometimes you'll hear them called brain attacks. And we know that there's two different types, right? We know that there's an ischemic stroke. An ischemic stroke is caused by a clot, and it leads to abrupt decrease in blood flow. Or maybe the individual is having a hemorrhagic stroke, and a hemorrhagic stroke means that one of the vessels is no longer patent and there's bleeding actually into the brain tissue. And what we know mainly is, as we've already talked about, the brain needs a constant supply of oxygen and glucose, and when this is interrupted, then we start to develop certain signs and symptoms that are indicative of a stroke. And those signs and symptoms are actually outlined on page 1389. And so we need to tell people, we need to tell the public, hey, if you experience, or anyone that you know experiences these signs and symptoms, that they need to call 911 and get immediate medical attention. So if they have sudden numbness or weakness or paralysis of the face, arm, or leg, sudden confusion, trouble speaking or understanding with slurred speech, sudden trouble seeing in one or both eyes, trouble walking, dizziness, loss of balance, or sudden severe headache with no known cause, they need to seek medical attention, because it is possible that they are actually having a stroke. Okay? We specifically are going to focus on ischemic strokes, and so we're going to flip the page to 1390. You guys know the drill, the modifiable versus the non-modifiable risk factors. And the non-modifiable risk factors for strokes include, our age, our gender, our ethnicity or race, and the fact that we possibly have a family history or, of someone in our family. When you guys are looking at gender differences, you can see that strokes are more common in men than women. And if we're looking at cultural and ethnic issues, we see that African Americans have a higher incidence of stroke than white. When we're looking at modifiable, those things that we can change, just like we've been talking about all year, hypertension, number one. Then we get into diabetes. We've talked about that. Then we get into heart disease. One thing that we've not talked about specifically is a condition called AFib. And AFib is an irregular heart rhythm that does not allow the atrium to empty properly. And when the atrium doesn't empty properly, then there's possible stagnant blood flow. Anytime you have stagnant blood flow, what do we know? We know then it's at risk for forming clots. So if someone who has AFib forms a clot and one of those clots breaks loose, then it can travel and it can cause a stroke, an ischemic stroke specifically. And that would be an example of an ischemic stroke brought on by an embolus. We also know that we need to ask people to control their serum cholesterols, to stop smoking. Of course, drink alcohol in moderation, and work on sedentary lifestyles and abdominal obesity. We know that Some individuals will have what we call a TIA, which is a transient ischemic attack. And this is just a brief neurological episode where they have some neurological symptoms, but these symptoms typically last less than 1 hour and they resolve. Still, it is considered a medical emergency, and often we call it angina of the brain. Okay, so this brings us to the type of stroke that we're going to talk about, which is an ischemic stroke. An ischemic stroke, fortunately, is the most common type of stroke. And as I said previous, it can be caused by a thrombus or an emboli. Okay? And so an emboli, as I said previously, could be caused, for instance, by atrial fib. An emboli typically has a lot more sudden and intense neurological deficits as compared to a thrombus, which is a blood clot, would have a more gradual onset. And so there is a chart that you guys can look over on page 1391, but remembering on this particular chart that we are focusing on just the ischemic type of stroke. So here is one of my wonderful drawings that's showing you how an ischemic stroke originates. An ischemic stroke happens because there's inadequate blood flow to the brain. It can happen, maybe there's partial or full occlusion of an artery. And like I said, the majority of these particular types are actually ischemic, which is good. And so the patient will develop neurological deficits. And this can either be from a thrombus or an embolus. Now the deal is that when someone is coming in and they are having neurological deficits or neurological symptoms, then we need to understand, are we dealing with an ischemic versus a hemorrhagic stroke, because the treatment options are very different. So what we know is that someone who has an ischemic stroke will not have changes initially on their CAT scan or MRI. They will not have changes initially. But when they do have changes, it will outline the area or the side of the cerebral hemisphere where the damage was done. As compared to someone who is having a hemorrhagic stroke, where the vessel, the artery itself, loses its patency and there is a sudden leakage of blood into the actual brain tissue itself, causing a sudden rise and increased intracranial pressure. This particular individual, when they show up, will have significant changes on their CAT scan or MRI immediately, helping us to determine the difference between the ischemic versus the hemorrhagic stroke. When someone does have a stroke, we know that they develop certain types of clinical manifestations, and we also know that they happen to be dependent upon the artery that was involved. And so for those of you following along in your book, you can see this on page 1393 at the top on table 58-3. What do we know? We know that because of the way that the brain is set up, we know that there is what we call a contralateral effect. So we know that, for instance, if someone has a stroke on the left side of the brain, the right side is going to have motor disturbances. And if someone has a stroke on the right side, then they're going to have their motor disturbances on the left side. So that is what we mean by contralateral. We know that, their motor disruption can be just suffering from weakness all the way to paralysis. And so it just depends on the artery that's involved, and it also depends on the extent of the circulation of the cerebrum that was actually compromised. We know that often these individuals end up with hypo and hyperreflexia, and that they end up with issues with swallowing and speech, and also their gag reflex, placing them at risk for aspiration. And so these are things that actually have to be observed and assessed when someone initially has a stroke. We do need to make sure that the patient keeps in mind and the family keeps in mind that when someone initially has a stroke, that there is cerebral edema, which is swelling of the brain. This is a secondary injury that happens, and because of this cerebral edema, it's going to take weeks to months before we know exactly where we stand with our deficits that initially occur. Many of them get better, much better, with time, but we do have to give them time. So if we look at page 1393 and we look at, for instance, right brain damage, then we're looking again that they would be paralyzed on their left side possibly. That's called hemiplegia, when you're paralyzed on half or one side of your body. That they could suffer from left-sided neglect. That they could have special perceptual deficits. That's extremely dangerous. They do not have good depth perception. They tend to minimalize problems, and they have a very short attention span and are impulsive with impaired judgment. As far as left brain damage, then we have someone who's paralyzed on the right side. Left means or can mean language. A lot of times people who have left-sided strokes do actually have impaired speech or language. They can be more slow and cautious, aware of their deficits, and therefore depressed and anxious. When we look at someone who is suffering from communication disorders, then remember we said that the left hemisphere is dominant for language, and therefore sometimes we say left language. And so these individuals are more likely to suffer from aphasia, which is just a language disorder. Okay, and so they're having issues with expression and comprehension of the written and spoken word. We have different types or different centers in our brain on the left side. We have what's called Broca's or expressive. And when someone has expressive aphasia, means that they can understand what you're saying to them, but they're having difficulty answering you. And so they often use very short words. They, as I said, understand, but because they cannot express what they want to say to you, they become easily frustrated. Then we have Wernicke's, which is considered receptive aphasia. Wernicke's, which is receptive. And what this means is that they understand what you're saying to them, but they have difficulty replying to you appropriately. So it gives an example that you may say, you know, that would say something such as, you know, it's really nice out today, the sky is blue, and they'll give you some long sentence that is irrelevant and has no meaning to it. And those are the two major types of aphasia that we're going to focus on. So then there also, in addition to the motor and communication disorders, there are what we call cognitive and behavioral changes. Certainly people who have strokes have a change in their affect. They can have difficulty controlling their emotions. They can be very unpredictable. They can have short attention spans. They can be anxious, depressed. This is someone who could possibly cry very easily now. It could be someone who, you know, beforehand never used foul language and now uses foul language, and so it makes it very challenging for the family to understand why they're having these particular changes, and you need to make sure that you help them to understand. They can certainly have what we call sensorial perceptual deficits, and sensorial perceptual deficits, as I said, different things that can happen. such as they can have a complete, or what do I want to say? They can have a complete neglect of their illness and their body parts. They can not realize that the affected side where the stroke has occurred belongs to them, and they don't take care of it. They don't remember that it's there. Therefore, when they get up to move, it causes injury. This can be worsened by the fact that you can have certain types of blindness that can actually occur because of strokes, where the blindness occurs in half of the visual field of both eyes. They might experience what we call apraxia. Apraxia is an inability to carry out something that they normally would be able to do prior to the stroke, such as pay a bill, brush their teeth, brush their hair, or they might also suffer from agnosia, which is the inability to recognize an object by sight or touch or hearing. And so, for instance, they wouldn't be able to recognize a comb or a brush. And so these are some of the different sensorial perceptual deficits that may occur. We're going to stop there for strokes. We're going to finish up in the classroom on taking care of the stroke patient. Next, we're going to just briefly go over headaches. Headaches start on page 1413 in your book, and we're just going to briefly go over the three different types that are shown in your book: tension, migraine, and cluster. First, a primary headache. When someone has what we call a primary headache, it means that we cannot really determine why they're having the headache. It is not being caused by a disease, or there are secondary headaches. Secondary headache is actually being caused by a disease or an issue, such as a sinus infection, or, for instance, someone who gets a headache from hypertension. When we look at tension-like headaches, these individuals complain of band-like pressure at the base of their skull. They say that the pressure is constant and it's squeezing, and there is tension in the neck muscles. And a lot of times these individuals complain of neck pain or stiff neck. A lot of people, you guys for instance, probably have tension headaches. They can often be brought on by stress, and they cycle on and off for many years, and there's actual palpable neck and shoulder muscle tension. People who have tension-like headaches, we just ask them to take a careful history, looking for what could be causing the actual tension-type headaches. They typically are controlled or treated with non-opioid type medicines. So we a lot of times just recommend that these guys take like an aspirin or acetaminophen or a non-steroidal. Possibly they might need to take a muscle relaxant too. When someone has a migraine is usually unilateral, meaning that it is just happening on one side of the head, anterior in nature, and throbbing. It usually or can have a trigger, and so a lot of times people can actually pinpoint or identify an event or a factor that caused the onset of the migraine headache. And a lot of times these guys will have what we call an aura meaning that it precedes the headache. And the aura a lot of times is a good thing in the sense that it allows the patient to premedicate. Different types of aura could be like they see flashing lights, bright lights, have some issues with patchy blindness, maybe sensory, they hear voices or sounds that don't exist or have strange smells, or maybe they actually have some numbness, tingling, some weakness maybe in like their face. And so like I said, this sometimes is a good thing because it actually allows for the individual to pre-medicate. When we are additional signs and symptoms for someone with migraine could be that they could actually, the pain's bad enough that they have nausea and vomiting, they're irritable, they sweat, they have different sensitivities to light and sound. These individuals a lot of times do take non-opioids, do take the acetaminophen, the aspirin. The aspirin is especially good because of the caffeine, or they might take NSAIDs, but they also take the triptans. A lot of times you guys hear people talking about Imitrex, and Imitrex is first-line therapy, drug therapy for migraines. And the reason Imitrex, sumatriptan, works is because it actually reduces neurogenic inflammation and produces or promotes vasoconstriction. This drug is best taken if it is given at the onset of the migraine. It is really good if it can be taken when the patient actually experiences an aura. Once again, the Imitrex actually is a vasoconstrictor. So people who have a history of, ischemic heart disease, or have peripheral vascular issues, or have hypertension, Imitrex is not a good drug for them. A lot of times, a second drug that is used is the Topamax, and Topamax is a medication that is actually usually given for seizures, but it has been proven to be effective for migraine prevention. If someone who does take Topamax, then the important thing about Topamax is it cannot be abruptly discontinued, or this may actually lead to seizure activity, and that it can have kind of a depressant effect, making them tired, and so they should avoid tests that require alertness until they're actually used to that particular drug. The last type of headache that we're going to talk about are cluster headaches. Cluster headaches often are unilateral or one-sided, radiating, and often involves facial bone pain. And on that particular side of the face, there's facial flushing and pallor. And these guys will take a combination of drugs, alpha drugs, SSRIs, steroids, or even lithium. Cluster headaches of the three are not as common. And when we look at nursing care for people who are experiencing headaches, we need to do a nursing assessment. When we do a nursing assessment, we want to just make sure that we have a really good history about the headache. We need very specific details about the headache, such as the location, the type of the pain, the onset, frequency, duration. You guys know the PQRST. Also, other information that we would need to know is, do they keep a diary? And can they identify factors that actually trigger the headaches? And it's important to keep a diary because then they hopefully know in the future which type of seizure or which type of factors to actually avoid. Need to go back here for a second. Well, it's not going to let me. Anyway, before we start on seizures, I missed the nursing care. So just acute pain is a good nursing diagnosis for someone who has a history of headaches. We want to make sure that we provide them with analgesics. We want to make sure that we place them someplace that's quiet, low lights, low stimuli, and that we could provide them with a moist hot pack. As far as ineffective health maintenance, we need to encourage them to keep a diary, especially to include activities, food, any kind of fumes or odors that might trigger headaches. We want to encourage them to exercise regularly. A lot of times people find that relaxation and meditation actually work in addition to analgesics. Okay, seizures. Seizures is a single event. It's abnormal electrical discharge in the brain. It's abrupt, it comes on suddenly, it's temporary, and it leads to an altered state of cerebral function. We know just because someone has a seizure that it does not mean that they have developed epilepsy. We want to be cautious in actually identifying someone as having epilepsy because of the fact that then they end up with many restrictions in their life. Okay, so when someone does have epilepsy, it is because they now have a history of reoccurring seizures. And it can be any of the types of seizures that we're going to talk about, but epilepsy means that they actually have reoccurring seizures. Seizures in general, a lot of times we call them idiopathic, meaning that we cannot attribute any one single cause as to why someone is having seizures. Epilepsy can have many triggers, and some things that are triggers for individuals could be music, certain odors, flashing lights, temperature, fatigue, certainly fluid and electrolyte imbalance, alcohol withdrawal, meningitis, any type of infections of the brain, brain abscess, brain tumors. I mean, it goes on and on as far as all the many types of seizures. There does seem to be a genetic link that runs in certain families, suggesting that there is a genetic tendency for seizures. If you look in your book on page 1420, there are two different types of seizures, focal and generalized. We're going to just talk about a couple in each category. Okay, but your signs and symptoms for a seizure actually are determined by where the electrical discharge is coming from, or where is the electrical disturbance. And when we have someone that has a focal seizure, it means just one cerebral hemisphere is involved, and while there might be an altered level of consciousness, there is not loss of consciousness. And so that's the difference between your focal and generalized seizures, guys. Okay, and so when someone has a focal seizure, it means that just one cerebral hemisphere is involved, and the signs and symptoms produced are related to what area of the brain is actually involved. Okay, and so a simple seizure is a seizure in which there is no impairment of consciousness, so there's no altered level of consciousness, and a complex consciousness is impaired, and they may have an aura, but there is not loss of consciousness for a complete focal seizure. Okay. The one thing that they might have with a complex focal seizure is what we call an automatism, which is just repetitive movement or motion. And so one instance might be someone who has a complex focal seizure would experience lip smacking. When we look at generalized seizures, what we know about generalized seizures is now that both hemispheres of the brain are involved, and this patient does experience a loss of consciousness. So that is a generalized seizure. And so we know we have two types that we're going to look at. Absence, they used to be called petit mal, but we're going to call them absent. Absent seizures is where there is a sudden brief loss of consciousness and motor activity. This particular individual often is considered to just be daydreaming or staring, okay? And it only lasts a few seconds, and it often goes unnoticed. It may be occurring as many as 100 times a day. And then we have what we call the tonic-clonic, used to be called the grand mal. There is a sudden loss of consciousness, and the sudden loss of consciousness is characterized typically by maybe someone falling to the ground. If they are upright, the body stiffens, and that is considered the tonic phase when they stiffen, and then their subsequent jerking of the extremities, that's considered the clonic phase. We know that during this, the patient can experience cyanosis, excessive saliva. They can have injury to their gums, their cheeks, their tongue, and that they also might be incontinent during a tonic-clonic seizure. Often people who have tonic-clonic seizures do experience an aura, meaning that they know that they're going to have the seizure. And then what we also have is a post-ictal phase, and this is actually the recovery phase where the patient experiences tiredness, might sleep for several hours to recover, and might actually have some muscle soreness during this particular time. Okay, so there is a medical emergency that can happen when someone has epilepsy, and that's called status epilepticus. And it is where the patient experiences a continuous seizure activity, or where they have one seizure right on top of the other seizure, and there is no time to regain or to recover, I should say. While status can happen with any particular type of seizure that we've talked about, it is the most dangerous, obviously, when it happens with tonic-clonic seizures. When someone has status epilepticus with tonic-clonic seizures, it can lead to exhaustion, hypoxia, acidosis, hypoglycemia, hyperthermia. And so it is considered a medical emergency, and it requires immediate intervention, making sure that the airway is opened. If there is a hypoglycemia, then you would put in an IV and give 50% dextrose. A lot of times they will give IV push medications such as Ativan or Valium, some type of benzodiazepine to hopefully break the seizure, and then possibly check their drug levels and see if their drugs that they're on for the seizures would be low, and possibly give them a dose of that particular drug IV, and then close monitoring to make sure that there is sufficient recovery. All right, so we'll finish up the care of the patient who is experiencing seizures in the classroom. And so let me know if you guys have any questions. Hey guys, I just want to say thanks for listening, and make sure that you listen to the neuro assessment videos and make sure you subscribe. Have a good day.